Hi, my name is Wendy Stav, and thanks so much for stopping by my poster to learn a little bit more about how occupational science informs occupational therapy practice. You can see from the center of my poster, we have these very strong foundational concepts of occupational science: doing, being, becoming, and belonging. We know that Wilcock and Hocking talks about those four constructs and how necessary they are for a person's health and survival. So just jumping back over, back in time a little bit, if we think about the development of the occupational therapy profession 100 years ago, it was grounded in the ideal that there was an inextricable relationship between occupation and health. And we continued to progress that way as a profession until the maybe 50s, 60s, 70s, where we really fell in deeply into some medical model practice for reasons I'm not going to get into. But just in the nick of time, occupational science was developed in the late 80s with the purpose of serving as the science supporting the power of occupation, to support the profession. So we took this idea, this doing, being, becoming, and belonging, which is very grounded in occupational science, and said, well, how does that shape how we practice as OTs? So we had this very strong press to use more occupation in practice, coming from both inside and outside the profession, but we didn't have a mechanism against which to measure our progress toward infusing occupation. How are we doing? Have we reached our goal yet? So Sarah Pasilis and I worked to develop a model, the dynamic model of occupation-based practice. We did a grounded theory study to really answer what is occupation-based practice and what are the constructs of that practice. There was another piece of those findings that looked at what are the things that influence whether we use occupation in practice or not. Ultimately, that study found four distinct constructs of occupation-based practice, which are authentic occupation, which is very linked to doing, so the client is actually doing something in practice. There's some meaningful and purposeful value to what you're doing, so it's tied into being because there's meaning and value for the client. The third construct is therapeutic intent. So that has to do with recovery and getting better and becoming my next more evolved, healthier person. And the final construct is engaged participation, which is most closely linked to belonging and that therapeutic relationship. And can the client belong, and are they engaged in that relationship? So the idea behind this model, and you can read about it more if you click this QR code at the bottom left, you can get the article that talks about the development of this model, is that when these four constructs are fulfilled, or when they're not fulfilled, it sort of spills out onto a continuum of occupation-based practice, with one side being very occupation-based, and the other side of that continuum is some other discrete model that is anything other than an agenda of health through doing. So it might be a medical model, an educational model, a psychological model, a military model. It could be any model, but the agenda is not health through occupation. So now that we had this model, it was great, but it's still all very theoretical. So we needed a way still to measure how are we doing in terms of using occupation in practice. So we developed the assessment tool, the occupation-based practice assessment, which you can see over here on the right side of this diagram. When we were developing the tool, we really didn't feel like we could separate authentic occupation and purposeful and meaningful value. So we combined them together into meaningful and purposeful occupation. So if you think about doing anything therapeutic with a client, whether it's repetitions of exercise or cooking in the kitchen, we're asking you to, we're looking at this assessment tool to measure how occupation-based that therapeutic interaction is. What are the materials being used? Are they weights, or is it a frying pan in the kitchen? What is the context of that intervention? Is it happening in a therapy gym or in an adaptive kitchen? Is there actually doing? So are you doing exercise repetitions, or are you scrambling eggs? What's the meaning associated for the client? What's the meaning associated with that exercise versus the cooking? Is what you're doing associated with the client's stated goals or occupational profile? The next section of the occupation-based practice assessment is about therapeutic intent. So is what I'm doing a deliberate therapeutic interaction, or am I just eating away at therapy minutes? And am I making sure that I'm adapting that interaction to create the just right challenge? And finally, the last piece is about engaged participation. Is the client participating? And also, what's the therapist collaboration? Are they engaged with the client as an occupational being, or are they sitting across the room working on their documentation? So this assessment tool, the occupation-based practice assessment, has multiple scales to measure different parts of practice. We can measure individual interventions. We can measure group interventions. When what you're doing is assessing or evaluating a client, we can measure that interaction. We also have a scale to measure assessment tools so that I can quantify how occupation-based the COPM is compared to, say, a dynamometer. The preliminary inter-rater reliability of this tool is very promising. You can get the full citation for that down here at the QR code at the bottom, but we're still doing further inter-rater reliability work as well as utility for self-administration. Ultimately, our goal is to be able to use this tool for individuals for professional development, so I can assess where I am and get a baseline, set some professional development goals, and then measure my progress. Hospital might use, or a hospital system might use the OBPA for program evaluation, so they can look at the aggregate of how all of their clients are practicing, because in theory, if the therapists are using occupation more in practice, their clients should be having better outcomes. They should have shorter length of stays. They should have less recidivism. So we can use it in that way with aggregate data. We can measure student growth during clinical competencies or during field work or even when writing up case studies. Because the model also has the piece about what influences us to be occupation-based or not, we can measure the barriers to occupation-based practice and then address them. And finally, we can use the tool in research to measure the effectiveness of occupation-based practice, or even to distinguish who's getting occupation-based practice and who isn't, so we can properly stratify our samples to finally definitively be able to say these folks who got occupation-based practice made more improvements than these folks who did not. Our next steps for this project, we've been working on this for many years, but our next step is to build the assessment tool into an app that has a searchable database. So somebody can enter their own data and then go back and pull their data to see their own trends, but that maybe a hospital system can pull the aggregate data of all the therapists that are working with them. Our next steps also plan on piloting the use of the OBPA in academic settings, and then finally using the OBPA to study occupation-based practice effectiveness across multiple practice settings and multiple populations. So again, I encourage you to scan that QR code in the bottom left where you can see references. You can get the full text of the article because it's an open access journal about the model. And hopefully now you are on board with me in recognizing that occupational science really does inform occupational therapy practice. Thanks for stopping by.